do I give a thumbs up? I don't do this often. Here we go. All right, good evening, everyone. It is with great pleasure that I welcome all students, faculty, staff, guests, and those streaming in to the very first Exercise Science Spring Senior Symposium. Tonight is an exciting night for our senior students from the Exercise Science Department. Our seniors will get to present their capstone projects that they have been working on since the end of last fall. These capstone projects are a culmination educational experience where program content, theory, and application are put into practice. As their professor and advisor, I have had the pleasure to witness these seniors develop and mature into young, budding professionals. I know I speak for all faculty and staff in saying how proud we all are of our hardworking first ever graduating class. Seniors, tonight is your night, and we are all excited to listen to your research presentations. You all should be extremely proud of how far you have come, so please enjoy every moment of it. To all guests, please feel free to ask our seniors questions and engage with their presentation afterwards. I could go on and on about how wonderful you all are, but I will save some of that for my speech next week. With that being said, we will officially begin our capstone presentations. I will be listing off what our seniors will be presenting, and then we will begin with Casey Allison. Casey Allison will be presenting the acute effects of alcohol on athletic performance and recovery. Michaela Bigard will be presenting on the predictability of the functional movement screening. Keith Jackson will be presenting on mind, body, and exercise. Madeline Lister will be presenting on changes in attitudes of women towards weightlifting. Emma Milikowski will be presenting on blood flow restriction training in postmenopausal women with osteopenia, a research proposal. Matthew Quinlan and Tariq Qureshi will be presenting on how COVID-19 has affected adolescents' exercise habits and ability to set and achieve exercise-related goals. With that being said, Casey Allison, come on up.
Thank you, Dr. Lachowski, for the introduction. Like she said, my name is Casey Allison, and my senior capstone project is on the effects of alcohol on athletic performance and recovery. So as an introduction, binge drinking, thank you. Binge drinking or heavy alcohol consumption is a common activity that student athletes or college students in general partake in, whether it's after a victory or a tough loss. So the definition of binge drinking is the consumption of 5 or more alcoholic drinks within a short period of time or within one sitting. Now, because this is such a common topic in exercise science and in athletics at the moment, several studies have been conducted on the responses of the body to large quantities of alcohol, as well as its effects on different athletic performance and recovery concepts. However, more research is definitely needed in this content area. So some statistics. According to a study performed by the NCAA in 2018, approximately 77% of student athletes reported that they drank alcohol within the previous year. 36% reported drinking on a weekly basis. 2% reported drinking on a daily basis, and 42% reported that they participated in binge drinking. Some sport and gender differences. Males are more likely to drink heavily as compared to females. However, within the past couple years, that gap between genders has been closing. And then lastly, team sport athletes like lacrosse or baseball or football are more likely to drink heavily than as compared to individual sport athletes like cross-country runners or swimmers. This could be partially because of the social connection with team sport athletes as compared to individual sport athletes. So the purpose of this review of literature that I've done is to examine the effects that heavy alcohol consumption has on athletic performance and recovery. I also wanted to identify whether there were any gender differences in the effects of heavy alcohol consumption. And I think this topic in general is very important for athletes, coaches, and exercise science professionals in order to have knowledge on this topic area and to prevent performance decrements, optimize training adaptations, and maintain good health overall. So basic outline of this presentation, you have it in your pamphlet in front of you, but I'm going to be going through the general effects of alcohol on the body, the effects of alcohol consumption prior to exercise and competition, the effects of alcohol consumption post-exercise on recovery, gender differences in alcohol effects, and then lastly concluding with some implications for future research. Starting off with the general effects of alcohol. So alcohol metabolism, 20% of ethanol, which is the chemical compound in alcohol, is absorbed in the stomach, and 80% is in the small intestine. The amount of time it takes for an individual to absorb alcohol varies between 1 to 2 hours per standard drink. However, this definitely depends on several different factors. A standard drink, as you can see, is 12 ounces of 5% ABV beer, 5 ounces of 12% ABV wine, or 1.5 ounces of 40% ABV hard liquor. In a binge drinking episode, however, the excess amount of alcohol is going to remain in the bloodstream for a longer period of time until it's metabolized by the liver, which is going to increase your blood alcohol content much higher and enhance its intoxicating effects. So like I said, there are several factors that are going to impact alcohol metabolism. The first being gender. Due to smaller body sizes and lower lean body masses, women tend to eliminate ethanol much faster than males do. However, women may also experience higher blood alcohol content with similar doses of alcohol. With age, alcohol elimination rate decreases with age, so younger individuals will eliminate and absorb alcohol much faster than older individuals will. And the fed and fasted state, I found this particular factor pretty interesting. Alcohol metabolism is much faster in a fed state as compared to a fasted state because of the increase in the ADH enzyme level, which is the enzyme in the body that metabolizes alcohol. Alcohol tolerance. As alcohol tolerance increases, your elimination rate also increases. And then lastly, exercise. Exercise has been shown to slightly increase alcohol elimination rate. However, I did put an asterisk there because it can be due to increased body temperature, catecholamine levels. However, more research, again, is needed to support or negate this claim. So some of the acute and chronic effects of alcohol consumption. So acute effects of binge drinking include slurred speech, decreased reaction time, balance and coordination problems, mood shifts, impaired judgment and memory, nausea or vomiting, and sometimes in the worst case scenarios, loss of consciousness or blacking out. Some of the chronic effects of binge drinking or due to alcoholism is neurological conditions such as tremors. Some people have reported having numbing sensations in the limbs, increased risk of cardiovascular disease and hypertension, increased risk of pancreatitis and type 2 diabetes, fibrosis or cirrhosis of the liver, and then some cancers, for example, of the mouth, liver, or breast. Some of the endocrine system effects from alcohol consumption. So first off, the functions of the endocrine system we know is to provide communications between body systems through the production and secretions of our body's essential hormones. It also controls metabolism and our energy levels. It helps balance fluid and electrolyte levels, and it assists in growth, development, and reproduction. So some of the effects of alcohol on these processes is it increases cortisol levels, which is the body's stress hormone. High cortisol levels is going to stimulate protein degradation or the breaking down of proteins, and is also associated with overtraining and reduced performance levels. Alcohol will also decrease circulating growth hormone and IGF-1. These hormones are functioning to regulate muscle protein synthesis and substrate metabolism during exercise or after exercise. Decreased testosterone. Testosterone has an important role in both men and women for reproductive development, muscle size and growth, and the maintenance of muscle size and growth, bone health, and ovarian function in females. The musculoskeletal effects of alcohol consumption is impairment of the mammalian or mechanistic target of rapamycin, what we know as the mTOR pathway. mTOR is composed of 2 distinct proteins that help initiate protein synthesis and support hypertrophy and strength gains. Alcohol has also been shown to reduce muscle protein synthesis during that recovery period after exercise or competition. It has been shown to have reductions in lower body strength and power output, and also increased inflammation of our muscle tissues. Moving on to alcohol consumption pre-exercise or competition. Starting off with the alcohol effects on substrate metabolism. So what substrates are and the metabolism is the breaking down of our primary substrates, carbohydrates and lipids primarily, for energy for exercise or daily living. So heavy alcohol ingestion pre-exercise will slow down the metabolism of those primary substrates due to alcohol metabolism preferability, because the body prefers to metabolize alcohol first rather than the substrates, carbohydrates, and lipids, for example. It will also cause alterations in the Cori cycle, citric acid or Krebs cycle, and pyruvate to lactate ratio. 2 studies also found significant increases in blood lactate levels in individuals who consumed heavy alcohol prior to exercise. And high levels of blood lactate is going to lead to reduced clearance of metabolites and faster rates to fatigue during exercise. Some of the alcohol effects on fluid and electrolyte balance. So fluid losses during long duration and high intensity exercise or competitions can sometimes exceed 5 liters per hour, which is a lot. Electrolytes like sodium is also going to be lost through sweat, deterring plasma osmolality and decreased performance levels in endurance and strength and power activities. So sometimes athletes and coaches will prefer to supplement with sports drinks like Gatorade in order to replenish those electrolytes either during or after exercise. Consuming alcohol prior to exercise can accelerate dehydration, and it can also impact those plasma electrolyte levels. For example, increased potassium levels. A study was conducted on male soccer players and found that consuming 0.7 liters of beer prior to a steady-state treadmill run significantly increased the plasma potassium levels. Plasma potassium levels do naturally increase with exercise. However, abnormally high levels of potassium in the body can lead to local muscular fatigue, cramping, and reduced muscular strength. In the case of severely high levels of potassium, for example, hyperkalemia, can cause worse symptoms such as heart palpitations and chest pain. Okay, moving on to alcohol consumption post-exercise and competition. Alcohol effects on mTOR and muscle protein synthesis. Heavy amounts of alcohol during the post-exercise and competition recovery period, which could be within 8 to 10 hours after exercise, instead of a protein and carbohydrate-rich meal, which is recommended after exercise or competition, can inhibit muscle protein synthesis. For example, researchers found that there was an approximate 37% reduction in muscle protein synthesis after the ingestion of large amounts of alcohol. Large amounts referring to the binge drinking of 5 or more alcoholic drinks within one sitting. Proper nutrition and recovery post-exercise is going to help us to reverse the exercise-induced muscle damage, and is also going to help promote muscle growth and repair. Alcohol effects on testosterone and cortisol and the testosterone-cortisol ratio. Alcohol and resistance training will have opposite effects on these circulating testosterone levels. For example, testosterone is naturally going to increase after exercise. However, after drinking alcohol, especially large amounts of alcohol, testosterone may actually decrease. Alcohol consumption post-exercise can disrupt recovery by reducing testosterone bioavailability in the bloodstream and/or the uptake of testosterone into the muscle cells. Decreases in this testosterone-cortisol level, or cortisol ratio, is also associated with overtraining, reduced physical performance, and decreased training adaptations, especially hypertrophy. Some of the alcohol effects on athletic performance. So performance reductions of both aerobic, also endurance, and anaerobic, strength or power activities have been studied in the days following binge drinking episodes. However, to my surprise, little research had supported a significant effect of heavy alcohol consumption on performance aspects, especially considering jump height, max or strength force levels, or sprinting speeds. Some potential reasonings to why these results may have occurred could be due to the amount of muscle damage that was inflicted. For example, some research studies will compare the effects of alcohol after heavy eccentric training, which is known to inflict more muscle damage as compared to basic strength training. The type of resistance exercise that is performed or utilized within the studies. For example, I found it pretty common that the exercise or activity that the researchers used was something that the athletes or the population that they conducted on was already conditioned to. So again, the muscle damage that was inflicted may have not been as significant, resulting in not as many results due to the heavy alcohol consumption. And then lastly, increased alcohol tolerance that hinders its effects, Like I said in the very beginning, binge drinking is a very common activity for student athletes and college students in general. So alcohol tolerance may have been increased in this population, hindering its effects of alcohol. However, regardless of this and all of these results, heavy alcohol consumption may not induce those acute effects on performance, but they can still make a very severe long-term impact on our general health and training adaptations. Some gender differences in alcohol. So differences in alcohol effects in men versus women. Most people don't realize that testosterone has prevalence and function in females as well as males. Testosterone in women, although it's produced at much lower levels because women don't have the glands that produce testosterone and is pretty much a result of a spillover from other glands. However, testosterone also assists in the maintenance of muscle mass and helps with other physiological adaptations in the body. Researchers have found that alcohol ingestion doesn't appear to affect the acute hormonal response in women as much as it is in men. It was also revealed that alcohol consumption after muscle-damaging resistance exercise does not have as significant of an effect on muscular performance, recovery, or inflammatory capacity in women as it does in men. Some of the similarities of alcohol between men and women, the alcohol effects. Another study examined very similar responses to heavy alcohol consumption post-exercise in both men and women. The results were that moderate amounts of alcohol following an eccentric exercise protocol reduced isometric, concentric, and eccentric peak and average peak torque. Therefore, from these results, it can be concluded that alcohol consumption following exercise induced muscle damage, initiated greater reduction in muscle performance and recovery between genders. In conclusion, basic summary from this research is that aside from general effects on the body's physiological responses, binge drinking behaviors can elicit some negative performance effects and can decrease rates of recovery. Pre-exercise and competition, alcohol consumption can be detrimental to performance because of its influence on substrate metabolism and increased risk of dehydration. Post-exercise and competition, alcohol consumption can blunt protein synthesis and alter mTOR signaling pathways. It can also decrease the anabolic hormone responses and can impact long-term training adaptations like strength and power. There may be some potential differences between males and females regarding the effects of heavy alcohol on performance measures. Lastly, some implications for future research. Based on the research that I found, a lot of these studies in the topic area have not managed to collect consistent data. The quantity of alcohol administered to participants doesn't usually reflect the average consumption rates of student athletes. Additionally, type or amount of muscle damage inflicted with exercise protocols are not significant enough. And then other factors such as alcohol tolerance or preconditioning to training regimens may also cause some discrepancy in the results. So future research within college athlete population should include the effects of alcohol and larger doses of alcohol that compares more to the typical binge drinking occasions in this population. And the effects of alcohol consumption after heavier strength and power types of activities that are more related to sport should also be included. And lastly, a lot more research is needed to confirm the similarities and differences in the effects of alcohol between genders. I think that the findings in this literature and the findings that I have in my presentation today will help athletes and coaches to understand the impact that alcohol and heavy alcohol, binge drinking consumption has prior to and after exercise competition on the different aspects of performance and recovery. That's it. Are there any questions? Dr. Pfefferly?
I just want to clarify something. Can you hear me?
Yeah.
Okay. You said that consuming alcohol prior to exercise decreases the amount of carbohydrates that are used during that bout of exercise?
It doesn't decrease, but the more alcohol that you have in your system, the body is going to prefer to metabolize that first. So it's going to kind of put the carbohydrate substrate metabolism to the side so it can metabolize alcohol first. So it isn't going to lower.
Wouldn't that be a beneficial thing to an athlete? If I can preserve, carbohydrates, then I'm going to have more carbohydrates and potentially fats to utilize at the end of my exercise.
That is
So
true.
would that be a beneficial thing?
I think so, but heavy amounts of alcohol, I wouldn't recommend. But I did find a study that kind of explored that area a little bit because there was a lot of discrepancies and different arguments on that topic. But the research article had compared beer, a non-alcoholic beer beverage that had like the same carbohydrate content in it, and then water or protein shake, on different effects of substrate metabolism and energy levels. And they did find that the non-alcoholic beer beverage had the most carbohydrate availability for substrate metabolism during exercise. So I think that it's something that could be included in future research, but I do think that from the results that I found, heavy amounts of alcohol is probably not beneficial prior to
One other
exercise.
thing, and you did a very nice job. We typically think about consuming alcohol in athletes as being a detrimental thing, like having issues with training. Are there any sports where consuming alcohol, especially right before I go and compete, could be a very beneficial thing, could be an advantageous thing?
Say the sports that involve like those high amounts of carbohydrates for quick, fast energy, maybe sprinters or swimmers or athletes that involve high strength and power activities, possibly.
Actually remember the name of that because I
Yeah.
heard recently that actually archery is where you can get a performance enhancer with alcohol.
Interesting.
Calms you down for stress out. So that's one example.
That's interesting. If no one heard that, he said archery. Yeah. Emma?
So, do you think enough is being done to kind of raise awareness for this? Or do you think that kind of coaches or athletic trainers just kind of let it go by the wayside? Because, especially in college students, they know that's kind of the climate that comes with college and, being on a team. They just kind of say, well, we'll put these restrictions out, be like, no drinking, 48-hour rule, whatever it is. Do you think they make it serious enough, or do you think that they don't?
In my experience, being a student athlete, I think it hasn't been as serious, and I think because of how common binge drinking and alcohol consumption is in this population, and of course from what we found that it doesn't have as many acute effects as we originally thought it did, that I don't think it's as like serious anymore, but it's definitely something that they are continuing to raise awareness for in the long-term effect. Yeah.
Thank you.
Anyone else?
All right, let's give her another round.
Thank you.
Michaela, you are up then.
Okay, so for those who don't know me, my name is Michaela Begard, and today I'll be presenting a review of literature on the predictability of the functional movement screening. So my research topic, basically what I was observing and analyzing, was the functional movement screening test and it as a tool to predict injury as well as enhance exercise programming interventions. So this is just an outline of what we're going to go over today. A little bit of an intro, as well as content section 1 on the functional movement screening test, what it is, who uses it, what are the 7 movements that are being tested, and why it's important for research. Oops, sorry. And then the content section 2 is on the FMS and the risk of injury. So is there a correlation between low FMS scores and high FMS scores, and which ones have a higher risk for injury based on the athlete's score? Content section 3 will be on the FMS and exercise programming interventions. So do these scores that the practitioners receive from the individual, do they help enhance performance, enhance the exercises that they pick, and will it help benefit the individual post-FMS test as well. Then the discussion, just to discuss a little bit about the limitations I found, the gaps, and just an overview of the entire research. So my main purpose for this research was to observe and conduct on the FMS. I wanted to investigate and observe if it was a good predictor for future injuries among individuals, as well does it play a role in enhancing programming interventions. And also just to find gaps to better understand the FMS test and it as a tool for screening. So a little bit of a background, functional, it's just the natural movements of every daily activity within an individual. And then when we look at it from a rehab aspect, when we perform functional movements, it's important to understand which ones are poor and which ones are good. So rehab specialists can make the necessary changes or modifications to programs based on the scores of an FMS. So again, content section 1 is going to be on the functional movement screening test, what it is, what the scores are, as well as the test, and why it's beneficial to use. So the functional movement screening test, we all know, is a simple screening tool. So it assesses functional movement patterns based on 7 different tests. So we know from just either in class or what professors have told us that it simply screens individuals for asymmetries within the body as well as movement deficiencies. So here are the 7 movement tests. The first one is the deep squat, so it assesses bilateral, symmetrical, and functional mobility of the hips, the knees, as well as the ankles. And then the next one is the hurdle step, so it assesses an individual's proper stride mechanics during the step in motion, as well as the inline lunge. It involves rotational, deceleration, and lateral movement types. And then the straight leg raise. So it assesses active hamstrings and gastrosoleus flexibility while maintaining a stable core as well as stable pelvis, and it activates the extension of the opposite leg from the one that's being raised. And the 5th test is the push-up test, so it tests the ability to stabilize your core as well as your spine in the anterior and posterior plane. And then the 6th one is the shoulder mobility, so it tests for normal scapular mobility. It's range of motion, combining with extension, internal rotation, as well as adduction. Then the last and final one is probably the most difficult test to perform in all individuals, whether they're athletes or regular people. It's the rotary stability, I'm so sorry. And then the proper neuromuscular coordination and multi-plantar trunk stability is also being tested in this test. So the FMS and scoring. You can get a total of 21 points for the max total score. In each test, the scores range from 0 to 3. So 3 being the best score, meaning you've completed the movement, no compensation, no asymmetries were found, and no pain as well. Anytime there's pain found, the individual will receive a 0. 2 means they complete the movement, but there's some compensations in some type of way. Also, most of the movements that are being tested are tested on both sides to assess any of those asymmetries as well. Here in the pictures, I gave some examples of FMS scoring criteria. So in the deep squat, as well as the hurdle step, you can see the individual is completing the movement. The deep squat, the knees and the ankles are parallel over each other, as well as the spine is in a neutral position. They're not leaning forward or they're not arching their back in any way. In the hurdle step, you can see that the hips, the knees, and the ankles are also parallel. They stay in that sagittal plane as they lift over that hurdle. And number 2, for the deep squat, you can see there's a little bit of a compensation where there's a block placed underneath the heel. So yes, the knees are aligned with the ankles, as well as the back is still in the neutral position, but there's a little bit of compensation and a little bit of extra support with the block underneath the heel. And then number 2, for the hurdle step, you can see that there's a little bit of a rotation as the individual steps over the hurdle. So you can see they're still they're leaning a little bit. There's a little bit more of a compensation when they perform the movement, but they have completed the hurdle step. And then 1, in the deep squat, you can see the individual has not completed the deep squat in any way. They're leaning too far over, their knees are either concaving or they're turning out. And then for number 1, the hurdle step, you can see the individual cannot complete the hurdle step. They cannot get their foot over the hurdle. They have very poor balance, very poor core stability as they try to attempt this movement. So when we look at the functional movements that are being tested here, they're based on proprioceptive and kinesthetic awareness principles. So proprioception is the awareness of the position of and the movement of a body, and it encompasses joint stability as well as joint position sense. So proprioceptive is basically motor control with movement of the body. Neuromuscular control also plays a major role within these tests. So the unconscious trained response of a muscle signal regarding dynamic joint stability is tested throughout the 7 tests. So why is this important for rehab specialists? Just like any screening tool, the PAR-Q or even the health history questionnaire that most rehab specialists use, it's important to set a baseline for an individual as well as set a direction for the practitioner. So the intended person of the movement screening is to identify any risk factors prior to the exercise, also assist in program designing using corrective movements or corrective functional movement patterns that we found were weak or asymmetries that we found, providing a tool to monitor any progress within prior injuries, as well as create a functional movement baseline. Content section 2. So we're going to talk a little bit about the injuries associated, as well as some studies that found any injuries associated while testing with the FMS. So the main question here is there a correlation between FMS scores and injuries? Many injury prevention specialists have used this tool to not only uncover limitations in joint stability as well as neuromuscular control, but also provide recommendations for individuals based on their scores. So we're going to look at a little bit of literature that I found based on FMS and injury prediction. So to start, Cobra et al. Looked at 38 Division II female collegiate athletes. The scores were recorded before they went into their season as well as after, and their injuries were also tracked throughout the season. So the key finding in this study was that a lower score on the FMS was significantly associated with an injury. 69 of these scoring less than 14 or had 14 as a score sustained an injury and were 4 times more increased for an injury. Hoover et al. Looked at 32 professional NBA and WNBA players. Only 27, though, were tracked throughout the season. The FMS scores were also recorded to begin. Number of injuries, the type of injuries, and the time lost due to these injuries were also recorded throughout their seasons. So in this study, a key finding was that 19 of 27 players sustained a non-contact injury and missed exposures as results. So in this study, exposures were anything an athlete was exposed to an injury. So it could have been practice, a game, or even a training session. The FMS score did range from 5 to 18, which is a very big gap. So that's something to look into as well. And then a sum of over 5,000 possible exposures were found. Of those exposures, 23% were due to non-contact injuries. 16.5 were due to contact injuries, and 60 were due to illnesses and personal reasons. So these numbers are very different. 60% were due to illnesses and personal reasons, which is something that the study before didn't find. 69 in the previous study, 69% were just from scoring less than 14. Then the last study I looked at was Duke, Martin, and Gall, who looked at 73 male union rugby players. Again, their FMS scores were recorded prior to the season and also halfway through their season. So time loss was also recorded throughout these seasons. And the key findings for this study was that the FMS scores of 14 or less were 10.42 times more likely to have sustained an injury in the first half than those in the second half. And in the second half, 4.97 were more likely in the second half as well. So just to wrap up and to sum all 3 of those sources that I found was that scoring less than 14 had an increase for risk for injuries. Here are 3 extra studies that I found a different type of injury as well. So Mocha, Sproul, and Gattens looked at 84 Division II, both men and women volleyball, soccer, and rowers. The FMS was performed before the season, and injuries were also tracked throughout the entire academic year, so not just their seasons, but off-season as well as postseason. So the key finding in this study was that one asymmetry on the FMS were 2.73 times more likely to sustain a musculoskeletal injury. So that's different from the 3 studies we looked at before of just the score of being lower than 14 or equal to 14. An asymmetry found also increased the risk for injury. So Chambers et al. Looked at 237 elite junior Australian football players. They completed their FMS test during the late preseason phase, and injuries were recorded during the season as well. One or more asymmetrical subtests was associated with a moderate increase in risk for injury. So again, that same one asymmetry test was found to have an increase for risk of injury. Same thing with Calise et al. Over 200 American football players. They looked at their FMS scores before and then the time lost and found again that one asymmetry on the FMS was 1.8 times more likely to sustain a musculoskeletal injury than those who did not. So again, the key findings in this one was that asymmetries played a large role in increase for injuries. So not only the 14 score or less, but also asymmetries as well. And then content section 3 is on the FMS and exercise programming interventions. So I'm looking at the FMS test when exercise specialists use it prior to their exercise programming. Does it help enhance the program or better the individual for post-score in the FMS? So here's some studies I looked at. 67 male athletes were divided into a work group as well as a controlled group. The control group did not participate in the intervention program, so they just completed their seasons, and then the working group did. So the FMS test was tallied before the intervention, and then they completed the intervention program to be 1 hour twice a week for a total of 12 weeks. So the researchers in this study found that before exercise programming, the average FMS score was 14.83. And after, they found it rise to 16.79. So that's a decent increase. Also, a significant difference in the amount of time was missed due to the injuries. So there was a difference between the amount of time missed for those in the controlled group and then those in the working group who performed the exercise intervention. And then Tijing, Middleton, Hung, and Dempf looked at 41 Division III female soccer, softball, and basketball players. They analyzed the changes after 3 to 4 months of an in-season intervention program, as well as these athletes still performed in their games, as well as practices throughout their season. So the key findings in this study was that there was an average of 15.52 of a total score on the FMS, which is a pretty decent score, higher than that 14, and then it increased to 16.04. Also, this study found that asymmetries in the postseason decreased from 24 to 15 at postseason. So those are the two key elements that we looked at, that score being increased above the 14, as well as the asymmetries being decreased to eliminate that risk factor. So just again to summarize some of the trends within the literature, individuals scoring below 14 found that the scores indicated a higher risk for injuries. Asymmetries or an individual score of 1 resulted in increase for injuries compared to those without. And then intervention exercise programs help improve post-FMS scores, decrease asymmetries, as well as clear any previous injuries. And for the discussion, we're going to talk about a little bit of the limitations I found as well as future research. So the 3 main limitations I found within these studies were the intrinsic risk factors, previous injuries, as well as sports-specific demands. So intrinsic factors are the ones listed here. So sex, so both male and females were looked at in different studies. We know that females are more susceptible to ACL injuries, so that plays a role in the gender intrinsic factor, as well as age. A lot of studies looked at young athletes, pro athletes, as well as collegiate athletes. Body composition, fitness level, so fatigue or muscle strength played a role, as well as health, so those previous injuries that I'll get into. And then some others included neuromuscular control, course instability, and contralateral muscular imbalances. These intrinsic factors are a multifactorial aspect that I think a lot of the researchers kind of missed out on, or they realized after they completed their study that it played a role in their results. So the previous injuries, so low scores of the FMS meant that they demonstrated dysfunctional poor movement patterns. So these previous musculoskeletal injuries, such as ankle sprains, ACL injuries, and torn rotator cuffs, were exposed after an individual performed the FMS test. So here's a study that directly linked previous injuries to low FMS scores. Duke et al. Looked at rugby players and found that those with low FMS scores had a previous injury. So this told them that particularly those who had the low scores and had previous injuries did not rehabilitate fully enough, or it resulted in poor rehabilitation results. So it altered a lot of their scores. It found them to be less than they should be since these athletes had previous injuries. So then another one that I looked at is the ACL reconstruction. Like I mentioned, that females were more susceptible to ACL injuries, and in this study, Kober et al. Looked at female athletes for those who had ACL reconstruction surgery compared to those who didn't, and they noticed that there was a direct link to FMS scores being lower due to prior ACL injuries among these females. So the ones who didn't have any ACL injuries or didn't have any prior musculoskeletal injuries, they had higher scores, and they directly correlated with just simply poor movement patterns instead of being an ACL injury where they found that these movements were compensated due to the prior injury. So some sports-specific demands that I looked at was that sports are very diverse and they demand a lot of different movement patterns as well. So we looked at a whole bunch of studies such as basketball, soccer, even rowers were included in many of the studies where they tested the FMS, but a lot of them didn't realize that it didn't correlate with realistic conditions that these athletes were performing in. So some asymmetries in the other functional movements, such as dynamic balance, running biomechanics, jumping landing biomechanics, and single leg postural stability. These are all performances that athletes have to do within their sport, when they're playing, when they're practicing, and the FMS simply doesn't correlate the same in realistic conditions. So, like I said, the sports demand are very different. Some use power, endurance, and involve changing direction, which the FMS does not test. The movement patterns are very stability-wise. They test asymmetries as well as movement patterns, so they're not realistic to sports. Hoover et al. Observed NBA and WNBA who played over 100 games in a season post-FMS scoring, and 60% of the injuries were due to illnesses and personal reasons. So that's a pretty high number. Fatigue played a huge role in this study. So a lot of them just simply were tired, were sick, and because they played over 100 games. And the FMS score just simply gave them scores based on that one type of movement. Also, they require a high velocity, impacts, and eccentric loads while playing basketball. So some future research that I thought should be suggested is that it should be concrete on individual observation. So a lot of the studies that we looked at had over 50 individuals being tested. So like one of the researchers that I found, their score ranged from 5 to 18. That's a huge gap, which didn't give us an accurate result of that 14 being the risk factor, determining the risk factor. So it should really also include the intrinsic factors that we talked about. Some of them we cannot change, such as that gender role, the male versus female, as well as previous injuries. We can help improve the previous injuries, but we can't simply change them and take them away. Then some intrinsic factors we can include. So the BMI we can change, as well as muscle fatigue, muscle strength, muscle power is something that we can change and help enhance as well. So for future research, I would suggest continuing to improve scores to above 14 through training or through rehab, as well as individualize that FMS testing like I was talking about before to accurately create exercise programs and lower the risk for injuries. So we want to make sure that it's definitely direct to the one individual. If we can get less than 5 as well, to really create a program that's tailored to them. And then as well as sport-specific exercise interventions, so post-FMS scores. So once we get those FMS scores, we want to not only create accurate programs for these individuals based on their scores to improve those movement functional patterns, but we also want to make sure that the exercise programs are sports demand specific. So we make sure that basketball players are working on their jumping biomechanics and landing biomechanics. We want to work on soccer players who are doing single leg stuff. We want to make sure that they can take what they have performed in these interventions and take them to the field as well. Any questions or comments? Yes, Dr. Lewis.
As you were doing reading the literature, did you see any talk about when they were conducting the FMS tests on these individuals in terms of where they were in their season?
Yes, most of them were performed during their preseason, so I believe they were starting out kind of working, doing a lot of conditioning, a lot of strength training, and then they did it right before their season starts.
Okay, so it's part of the lead up.
Yep, so they did, some did both prior to the seasons or postseason.
What do you think might be important about that? Like, why would you want to do it preseason versus mid-season versus end of the season, do you think?
Well, a lot of the studies did the preseason to see where the individuals were before they kind of hit that fatigue level. Like the basketball example that I used, they played over 100 games. So if you do it kind of midway through the season, you can kind of see that fatigue setting in as well as any injuries that the athlete may sustain during their seasons as well. Yes, Chris?
As a like a practitioner, how would you like implement like functional movement screening to in like a population, say like collegiate athletes, to track their progress throughout a season and know when to like pull an athlete if they're like at too much risk for an injury at a certain point?
I think that so you should definitely do it like a lot of the research was doing it right before like right in preseason kind of setting where you can, or even right before preseason starts, where you can create that program so they can either advance in those functional movement patterns, or you can test them kind of in the middle to see if if they've had an injury or they've been have some lingering like muscle torn. You can kind of test them to see if there is some weakness or functional movement patterns that may be a higher risk for injury. I wouldn't say you should use it as like a determining factor for athletes to kind of pull them out because it is still just a screening tool, but further research should be done on that as well. Yes, Dr. Pfefferly.
You use this term asymmetries quite a few times. What is an asymmetry?
So it looks at both the left and the right side of the body, so it kind of splits the body in half in a way and determines if you can like perform an exercise on the left side compared to the right side as well.
And so what the FMS is assessing is whether or not there is a difference in movement from one side to the other side.
Yes, so
There are too much of a difference there, there's a greater potential for injury.
yes, so many athletes are either left-handed or right-handed, so that plays a role in like being you're more stronger on one side compared to the other. So that definitely will play a role, especially in like knee injuries as well. They say you're not as like stable or strong enough in that like the weaker side.
If after I assess someone and I determine that they have an asymmetry, my goal for training would be to try and reduce the asymmetry between those two sides.
Yes. So that's where the sport-specific demands come in. So if you're working maybe with a baseball player and you notice that their shoulder mobility is stronger on one side compared to the other, you might want to kind of incorporate that into the program.
Okay, so I'm going to throw this at you.
Okay.
Baseball player. Have you ever worked with or seen a pitcher before, an overhead athlete, like a baseball pitcher?
Yes.
Have you ever looked at them laterally, so they're two sides?
Yes.
What did you notice when you looked at those athletes, the two sides of their body?
Well, you can tell one is definitely more stronger just by looking at kind of like their lats, their traps as well. You can see that it's a complete difference in muscle strength just from one side to the other. They could be relaxed as well. I've seen it in even wrestlers where one side is completely stronger, and you can tell when they flex or even when they're relaxed that the muscle is definitely stronger on one side.
Working with, let's say, Trevor Bauer. You know who Trevor Bauer is?
No, I do not.
I'm not picking on you. I have issues with the FMS.
Okay.
Trevor Bauer is a pitcher for the Los Angeles Dodgers. Very good pitcher. Major asymmetries from one side of the body to the other side of the body. Should I try to alleviate those asymmetries if I'm dealing with an athlete of that caliber?
I think it would better enhance their performance if needed. But those athletes tend to be kind of one-sided. You would never kind of throw with your left if you're a pitcher in a way.
Last question.
Okay.
You mentioned the FMS does not resemble, the movements in the FMS does not resemble movements commonly found in most sports. There's no running.
No, it was kind of like they test for those exact examples, so running, some jumping, some single leg stuff, but they're not in real conditions. So when people are at full speed running, their proper stride mechanic may be different from simply stepping over something.
Why would I?
I believe you should use it to, if you can't do it, I feel like in a normal setting, I feel like it might definitely play a role in that performance setting. Thank you.
Yeah, I know. All right. My name is Keith Jackson, and I did my presentation on the mind, the body of, and exercise on adolescents ages 8 to 10. So exercise adherence, this is the commitment to stay physically active on a regular basis. So what I want to do here with these adolescents ages 8 to 10, I want to increase their exercise adherence level. I want them to be committed to exercise, physical activities. So with that's going to take motivation, and it's going to take motivation and encouragement, whatever it may take from the staff and the clients itself. Reasons for exercises, you have like weight control, reduce risk of cardiovascular disease, reduction of stress and depression, enjoyment, build self-esteem, and socializing. Reasons for not exercising, so you have perceived lack of time, lack of energy, lack of motivation, lack of money, lack of social support. So 3 here that are big, and then you will see more in this presentation is like lack of motivation. Like, especially at this age, it's very important to be motivated, self-motivated, motivated by others is very important too. Another one is lack of money. So lack of money is very important because based on your income, if you have lower income, you're at a slight disadvantage. You might not be able to get that personal trainer, a gym membership, or equipment to actually stay physically active. Another one is lack of social support. Especially at this age, lack of social support is very important. Like, so most kids, we live in a society where kids just love technology. Everybody loves technology nowadays. So if they don't have that social support, like a parent or maybe a friend that's going to keep their child physically active and sign them up for these activities like personal trainer or a sport maybe, they might just be stuck on technology. Some determinants of exercise, you have demographic, cognitive personality variables, social environments, and behaviors. So starting with demographic variables, so you have education, income, social economics. So like I said earlier, income is big. So the higher the education, which will mean the higher the income will be. So those are the people that might have an advantage over the ones who don't have the higher education and the higher income. Those are going to be the people who will pay for the personal trainer, who's going to pay for the membership and have the equipment to actually stay physically active. All right, now cognitive and personality variables. So here, self-motivation is big. Like I said earlier, you want to be able to motivate yourself. You want to motivate yourself to keep going, to keep thriving for greatness and to stay healthy. And along with self-motivation, if you have self-motivation, you're going to be able to motivate people around you. So that's also key, especially at this age. These people are around their peers, their friends, and they're very well influenced by their peers. So if you have great self-motivation, you're going to be able to motivate everybody around you in the environment around you. So modifying knowledge, attitude, values, and belief regarding physical activities can influence the person's interest to be active. So now, social environment, this is back to the social support. Like I said earlier, kids are stuck on technology. They want an iPad. They want these game systems. So by social support, I mean like a parent that's going to actually sign their child up for a gym membership, like I said, a personal trainer. Sports, they need that one parent that's going to encourage them to keep going. They need, or even a peer, like I said, they're well influenced by their peers. So if they see a friend doing something, they might want to tag along. And behavior, this is probably one of the most important determinants on this. So this is around the age where they should be getting encouraged to be more physically active. This is where behaviors are being created and habits are being created. So at this age, you don't want to create bad habits for yourself. You want to create great habits. So, and that goes along with encouragement. So encouraging these kids to stay physically active, and that's going to take, like I said, the support cast that you're around, the people who's going to support you, like your parents, your friends. So you just need to encourage them to be more physically active. And so this adolescent stage, they're well influenced by their peers. Like I said, they're around for the most part, like other than being because of COVID, due to COVID, like for the most part, they're around their peers, they're around their friends, whether it's at school, after school, in school programs, whatever it may be, they're well influenced by their peers. From my time with these kids, for the 6 weeks I was with these kids, like I've realized that they are well influenced by their peers. So like if one was having a bad day, they all were having a bad day. If they were having good days, they all were having good days. And this is the age where they're finding themselves. They're developing self-esteem and confidence, and that goes along with encouragement. Like if you're encouraging your child to do something or encouraging a friend to do something, and you see that they're doing great at it, that's gonna build their self-esteem. That's gonna build their confidence. So do here, because a lack of self-esteem and confidence can determine a child's want to participate in physical activity. So, like I said, self-esteem and confidence is big here. And ways to increase exercise adherence in children. So you have improving motivation, that building support system, encouraging positive mindset, which all of these will encourage a positive mindset, like improving motivation, building support system, constructive criticism, and making the exercise enjoyable. This is also another big one, was especially at this young age, age 8 to 10, you had to make the activities and exercise enjoyable. Like you had to make them want to do it. Like if they didn't like it, they're gonna do it, but they're not gonna participate the way you want them to participate. So you have to really engage, make the activities and exercise enjoyable so they will participate the way you would want them to do it. All right, so now we get to my research question. So what effects does consistent group exercises have on children's overall well-being meaning physically and mentally? My goal was to install the wants and desire for a group participates in exercise after a program ends, making it part of their lifestyle. So I just wanted them, like I said, I wanted it to be joyful. I wanted them to love it. I want them to continue to keep staying physically active, keep exercising, maybe join a sport, whatever it may be, but keep your body moving always. Stay physically active on a regular basis. That's what I wanted from them. I wanted them to get it stuck into them so they can continue to stay physically active into the age that they're at now, into their teens and all the way to adulthood. So now my capstone, I did a community-based intervention, child's 8 to 10. I had 10 clients, 4 boys and 6 girls. My purpose was to promote and educate about benefits and importance of regular exercising. So my methods, I did, the location was at Continuum Performance Center, duration 2 times a week for 6 weeks for 75 minutes a session. And now we get into the 5 components of exercising. For the most part, I fit these each all into my activities and exercises that I did. Like for the most part, I fit them all in. The only one I really couldn't fit in due to resource at the gym was body composition. But I fit in flexibility, muscular endurance, muscular strength, and cardiovascular endurance. And this is how I organized the session. So I held a session with a word of the week, starting with a word of the week, and that was the focus of that week. So every activity, every exercise is focused on that word of the week. And then we get into the group activities. So the group activities were structured by blocks. So block 1 was the exercise circuit. Block 2 was the activity. Block 3 was speed and agility. And block 4 was another activity. And then we will educate. And then I'll educate them on the benefits of the activities that they completed that day, and if they had questions. So week 1, so these kids is 8 and 10 year olds. I didn't want to start barbell movements with them. Some of them were not that coordinated, so I didn't want to really go into barbell movements with them yet. So, but some of the workouts that they did was like TRX rows, kettlebell goblin squats, mountain climbers, push-ups, reverse lunges, TRX squats. But the main focus was the word of the week. The word of the week that week was motivation. So I just wanted them to be able to motivate themselves, be able to motivate others. Like an activity that we did that week was like a intrinsic motivation and extrinsic type of activity, like where they were starting with intrinsic motivation, where they held a high plank, and whoever can hold it the longest, and they did it all together in a group, circled in a group, so where they're externally motivated by each other, they're motivated by who wants to win, things like that. So they're motivated by externally, like the things around them, their environment around them, and then after that was done, I faced them against opposite directions, so they weren't really facing nobody. So they're intrinsically motivated. Whatever they had personally that was motivating them, that's what really motivated them. And I realized they were most of them held the high planks longer in the external motivation. So that was really, then I engaged with them and had a conversation with them, like, because you should be able to motivate yourself with just you, like. So that's what I really want to get them is, like, what was your reason why? Like, you need to have a purpose. Like, you need to love this, because most of them actually, like, do sports. They participate in some activities, like y'all had lacrosse, basketball, football, skiing, like, so things like that. So I just wanted them to be able to motivate themselves, like, because not every sport life, like, you just have to be motivated in life just to do things by yourself and on your own. And week two we did workouts like kettlebell swings, TRX, chest press, cycle jumps, box high knees, push-ups, body weight squats. And the word of the week was goal setting. So as you see here, there's no reps. The reps are for, like, time now. And I wanted them to set a goal for themselves, for they can achieve that goal. I want to see how many reps that they can get in that amount of time. I wanted them to push themselves instead of, like, getting that rep. Like, so I wanted them to reach the goal and set a goal and achieve that goal. And I also, for the activity, I also sit down, had a I spoke with them about goal setting, and then I had them each write down goals and how they're gonna reach that goal. And I hung it up on the gym wall. And I also wanted them to create a long-term goal for themselves and how they're gonna achieve that goal. Week 3 was like the exercises went about like TRX rows, skaters, burpees, vintage burpees, TRX Ys, kettlebell swings. The word of the week was confidence. You got to be confident in yourself and confidence in the things you do, especially in life. Like, it's not only in the gym, not only staying physically active, you have to be confident, but you have to be confident in life, confidence in the things you do. You have to believe in yourself. And that's what I wanted from them. I wanted them to believe in themselves and believe in others, because most of these athletes or most of these kids is athletes, and they just have to believe in others and believe in themselves. Week four, some of the workouts was like jump ropes, Spider-Man mountain climber, sit-ups, kettlebell high pulls, box dips, burpees. The word of the week was challenge. I wanted them to challenge themselves, challenge each other, push past that comfort zone. And week 5, so this is where it started to get nice out. This is when it started to get nice out. So I wanted to take them outside. So yeah, they had a exercise circuit before we went outside though. So I wanted that to complete it. And then this is when I started getting the complaints about they were on Zoom all day. I had a tough day. They didn't like being over Zoom all day, so I wanted to get them outside. So here, the word of the week was commitment. So some activities we did was like kickball. They might have ran around, played tag for a little bit. But the focus of this session was to commit to one another, commit to their team, motivate to their team members, and work together. So during this game that I had with them, they played a kickball game. Like, then now they're with me. They've been with me for about 4 weeks, and we've been going over like motivation, confidence, being confident in yourself, trusting each other, motivating each other. So actually seeing them with an organized team event, like I seen them using it. I seen them motivating each other. They were more confident in each other, and they were all sticking together and working as one and together. Week six was teamwork. And this was another week where I held the activities outside more. So they did things like partner relay games, wheelbarrow, egg and spoon relays, crab walks, three-legged race, run relays. And same thing here, like I just want to see them use what they've been learning and what I've been teaching them, what I've been talking to them about, like just motivate each other, be confident in yourself, and everything will work together. And so, but like here, I wanted them to just enjoy their time with me though. Like I wanted them to enjoy the exercises they were doing, the activities that they were doing, because that's very important, especially at this young age. You got to enjoy it. And evaluation method, so this is my surveys that I held, so gender, age. But the most important ones is 4 through 8, like when you woke up, how'd you feel? Prior to coming to the gym, how'd you feel? How'd you feel while you was participating in the activities? How'd you feel now that the activities are over? Are you likely to participate in these activities again? And so these are my results. So question 4 being here, as you can see from week 1 to week 6, the results rise. Question 4 was how do you feel when you woke up? Question 5 is how do you feel prior to coming to the gym? Question 6, how do you feel during the activities? How do you feel? And question 7 is how do you feel when the activities are done? And question 8 was are you likely to participate in these activities again? So as you can see, all of them rise from week 1 to week 6. So my discussion, the average scores increased as the days went on. Average scores increased on a weekly basis. Children report feeling tired prior to arrival to the gym and the session feeling energized, which is what I want. I wanted them to feel energized. I wanted them to have a great time with me. So children report the biggest takeaway from this sessions were to be confident in themselves, be a team player, and support one another. Children also report feeling bigger, stronger, and faster than ever before. So some limitations, big limitation was COVID. COVID had a really big impact on the world. So most of these kids is over Zoom for about 7 to 8 hours a day, which they did not love at all. So they're over Zoom for 7 to 8 hours a day, and then they're coming to me afterwards. But the biggest limitation was COVID because damn, I'm freezing up. Yeah, a limitation was COVID. COVID really impacted the world. So these kids is over Zoom for about 7 to 8 hours a day, and then coming to me for about 75 minutes of the day. So I just want to make it enjoyable for them because like I said, like damn, I'm lost of words right now. So future research, important to understand the needs of exercise and youth, address concerns earlier can prevent negative long-term effects, worth research and effect COVID-19 did have on the youth. How can physical activities be used to help play reverse effect of COVID-19? Any questions?
When did you complete this intervention? It's like, that was really cool.
Thank you.
When did you complete that?
I finished it about 4 weeks ago.
I work with kids, so it's kind of cool to see. I have worked with kids, so it's kind of cool to see.
Now, yeah, working with kids was amazing because I work with at my internship I've been working with college athletes, high school athletes, and then working with kids is actually pretty different because like most of the high school athletes and college athletes, they have I feel like they have more of a purpose. So like things is not enjoyable. Like at that high school and college level, like you're gonna feel the pain in conditioning. You're gonna feel the pain when you're working out, and like for kids, especially 8 to 10, like you're gonna have to make the activities a little different. Like especially like speed and agility. Like you're not gonna just say run on the line. You got 60-yard shuttles. Like you have to maybe like put color cones down, saying, all right, we're gonna play a little game. When I say blue, run to the blue. When I say red, run to the red. Things like that. So working with kids was just amazing because like I felt like while they were enjoying the time with me, like I was kind of enjoying the time creating the activities that they were doing. Dr. Lachowski.
So Steve, you talked about at the beginning how kids and their peers like are heavily influenced by each other. So you probably saw that firsthand each time you're with them. So you said when one was in a bad mood, kind of seemed to trickle throughout the rest of the kids. And you didn't know what to expect each day, right?
Yeah.
So you almost have to be prepared for whatever at that point in time.
Yeah.
So when they were in, let's just say, a down mood or something like that, how did you get them out of that mood? How did you get them then excited? What did you do as a coach?
So as a coach, to get them out of that down mood, like I said, like it's tough, like because when one was having a bad day, like they really were all having a bad day, but when they were having a great day, they're all having a great day. So I'll try to just like motivate them, whatever it took to really motivate them, because you as you through the weeks, as you keep working with them, you realize what they love to enjoy, and you love and you know what they hate. So from week 1 to week 6, from week 1 to like week 3, I really knew what they enjoyed, what they hated. So so I kind of made that, like most of the activities and exercises were based on the things they enjoyed. So like I didn't have to deal with the not bad behavior, but the I want to say lack of like the motivation to participate in the activity. So I'll just try to really make it enjoyable. Like I knew what they liked and I knew what they hate. So
So then if you made it enjoyable for them, do you think as they age, they're going to want to exercise more? Adherence is going to go up if it's enjoyable, right?
yeah.
Yeah, absolutely. Great job.
Did you talk to them about the benefits of exercise at all, or was it mainly just focusing on time and these psychological aspects like motivation, commitment into the exercise you're having to do?
Yeah. So I've really focused on like the just like really the exercise part and the motivation and self-confidence and things like that. Like so I didn't really focus on that part of it.
The basis of your presentation and the little research you did is determining what motivates these young people, correct?
Yeah.
Can you give me a definition, a psychological definition of motivation?
So so motivation is like to me motivation is like a why, a reason why, like a purpose, like a reason why you do something. Like I even explained to the kids, like it's like your reason why that you do something is deeper than what people actually think. Like my reason why may be different than everybody else's. Like people just don't wake up every day to just work out, exercise. Like some people have real reasons. Like for example, me. Like one of my reasons to exercise is not to get better at the sport I do, but one of my reasons why is because I'm going to school for free on scholarship due to that. Like so, it's deeper than what it actually what it actually is. It's deeper than motivation is deeper than what people actually think. Like people just like me. Like I don't just work out to get better at a sport. Yes, that's gonna help, but it's deeper than me. It's deeper than that to me.
So when, let's say somebody that looks kind of like me with a shaved head and a big white guy yells and screams at people in a weight room, is that motivating to every single athlete?
No, that's not motivating to every athlete. No.
So
Yeah.
So if you were to give a strength coach or a football coach or somebody like that recommendations on how to motivate young people, what would you tell them?
Just to, at this, like, I'm gonna use these kids as an example again, like the 8 and 10-year-olds, to just how to motivate them is just try to keep the activities and exercise and enjoyable, like keep them on pace, keep them on track. That's what's gonna really get them enjoyable. When they're having fun, that's the main thing, is allow them to have fun. Because when you take it too serious, like as you get older, it's gonna get more serious. Like now you're dealing with strength coaches, like college strength coaches, it's gonna get more serious. But they're at the age where they're finding themselves. They're now learning. They're not really physically active, but they're getting physically active. So you just got to make the activities fun.
Very good.
All right. So I'm Maddie. I did my capstone presentation on like changing the attitudes of women on weightlifting and kind of seeing the best ways to do that, as there are a lot of kind of stigmas about women lifting. So some of the research that I looked at, which helped me kind of guide my study, I guess, looked at what barriers there are for women in weightlifting. Peters et al. Used a survey to look at a few different categories of barriers to see which were most had a larger impact. And Harn and Bixby looked at barriers as well as the understanding of the benefits to see if one had a greater impact than the other, to see if like the barriers were more, would stop them more than knowing the benefits. And then Cadmus, Bertram et al. Looked at specifically women living in a rural setting to see how their needs would differ from another population. And my hypothesis or research question was said women may have increased barriers to resistance training. However, participation in a training program will improve their outlook and increase their likelihood of participating in the future. So my participants were 3 women who had a gym membership already, but were not participating in resistance training. They were primarily doing like cardio and kind of circuit style training. And they had been exercising for at least 6 months prior to the start of this program. And I created a 26 questions survey, which kind of looked at a lot of different variables which could impact their likelihood of participating in lifting, like if they were uncomfortable in a gym, like in the gym alone, they didn't know how to use the equipment, that sort of a thing. I did collect pre and post intervention surveys to see the changes over the program. And then the training program itself was a 3-week program which was focused on like powerlifting style weightlifting, so a back squat, bench press, and conventional deadlift, as well as other accessory movements which would strengthen those lifts. So in the first session, we did the initial survey and then optional measurements to see how they changed over the program. The participants came for 3 to 4 sessions for 3 weeks, and we broke the sessions up by muscle group instead of total body based on what they preferred and how they would have liked to exercise. So those were broken up into a back, chest, legs, and then arms and shoulders. And then began with main lift, so back day was deadlift, and then we moved into like lat pull down and similar accessory stuff, and then so on throughout the list. And I found that not all variables that I looked at had mean differences, even though there were individual differences between the women. So some of the mean differences that I found were feeling uncomfortable lifting alone, uncomfortable in a crowded weight room, not knowing how to use the equipment, didn't want to look silly or uncoordinated, especially in front of more experienced lifters who already know what they're doing, and being interested in learning more of the benefits, as well as potentially continuing with either personal training or continuing with some sort of a training program. And then almost all of the variables, I found individual differences, which included, I don't know, especially like women, a lot of them were afraid of lifting in front of the men because they weren't sure like if that was going to be an issue. I don't remember the rest of them. And then improvements in strength, all of the women saw improvements from the first week to the third week, and although it is a short duration, it was really cool to see how they improved and how they felt more comfortable, and therefore were able to push themselves a little bit more, and just seeing how their attitudes like physically changed throughout the program, which is super interesting. And then my key takeaways from leading this study were all of the participants displayed changes in their attitudes and were more likely to want to participate in the future, and I could see them becoming more confident, and it was really awesome to be a part of that because especially like when I started, I had somebody help me and teach me everything, and it definitely helped a lot knowing that I could make mistakes and fail on a lift. So yeah, and then limitations that I found were a very small sample size. Ideally would have liked to have more participants, but here we are, and then a very short duration of the program to not see very much changes in strength. And yeah, any questions? Dr. Lewis.
You mentioned that the participants all participated in exercise for at least 6 months. So why did you make that statement? Do you think that's important?
It just shows that they had been participating in some sort of exercise, so they weren't completely new to exercise in general, so that they had some sort of a baseline.
Do you think you would have worked with them any differently if they had not been participating in exercise?
Not necessarily, just because they hadn't participated in weightlifting, so they were still new to that. I just thought it was interesting to notice that they had been working out a little bit in some fashion. Dr. Pfefferly.
You mentioned that the participants had an attitude change towards weight.
Yes.
What is attitude?
So they felt less negatively and that they could actually do it, and they weren't as afraid to try as it was very new to them. They were definitely uncomfortable in the beginning and weren't really sure about it.
Can you give me a definition of what attitude? Attitude is a psychological concept. What is the definition of an attitude? If you had to define it.
Definition of an attitude. So I'd say it's kind of like your perception of like how well you will do and your confidence in yourself in whatever it is. So lifting for these women. I don't know. I feel like there's a lot to attitude.
On the right path there is how you view a person, a place, or a thing. So can you go back to the slide right before that?
This one?
Yeah, that one.
Cool.
You say that the women became more confident in themselves. Would that influence their attitudes towards weight?
I believe so, yes.
In what way would it influence their attitudes towards weight?
Because they viewed it in a more positive way than they did in the beginning. Yes.
You said that they wanted, but they were afraid to lift in front of men. And at the end of this study, were they okay, or could they tolerate lifting in front of men at the end of the study?
Yeah, so it wasn't necessarily that they couldn't, it's just that they were less comfortable doing it because of the typical like gym bro attitude, but they were definitely seemed more comfortable at the end than they were in the beginning. Any other questions? Cool.
All right. So hello, everyone. I don't know, can you hear me, everyone? Okay. I'm Emma Milikowski. Thank you all for being here. Today I present my research proposal on blood flow restriction training in postmenopausal women with osteopenia. So this is a little introduction to my proposal. As much as it is important to me and exciting for me to talk about this, it's also extremely important to the scientific community. The combination of factors that are in my research proposal are vastly underdeveloped in the research, specifically postmenopausal women in the exercise science realm, as well as blood flow restriction training. With postmenopausal women, a lot of the existing research pertains heavily to resistance training, the effects of resistance training, which are extremely important. But it's also really important to investigate other forms of exercise, such as the BFR, which I'll refer to it as BFR from here on out, because blood flow restriction is it's a little tongue twister. But anyway, so BFR studies, a lot of the studies have been done in younger, healthy populations, which is also extremely important as it is a novel exercise modality. But it needs to be, now that it's been established as very effective, it can be moved into special populations now. There's also even less research on the effects of BFR on bone mineral density, which is highly important in postmenopausal women with osteopenia, and I'll get to that in a minute. So the purpose overall for my research proposal. Ultimately, it's important for me and the community to understand the application and effects of BFR, especially in postmenopausal women with osteopenia. It's a potential to decrease the risk for osteoporosis for a few different factors. And it's also, another purpose would be to compare BFR to traditional resistance training in the exercise science realm. Specifically, is mechanical loading necessary to induce positive adaptations or effects on bone remodeling? Lastly, it's also important, like I said, to raise awareness for alternative exercise interventions methods, so that way, as health professionals or medical professionals in the field of exercise science may be able to create more specialized treatment methods for people in special populations, such as postmenopausal women. My overall research question that led me to this topic, does blood flow restriction training in postmenopausal women with osteopenia promote significant muscular adaptations such that bone remodeling is amplified? Now, I hypothesize that blood flow restriction training will elicit significant increases in metabolic accumulation and muscle adaptations, which prompt enhanced regulation of bone remodeling, such that there will be increases in bone density and possibly a reduction in the risk for osteoporosis. So that's my introduction. Now I will go into a little bit about the population and what BFR is and other exercise prescriptions for postmenopausal women. So menopause is a period of time in a woman's life defined by 12 months of amenorrhea. Amenorrhea is the absence of a menstrual cycle caused by primary ovarian failure and the depletion of oocytes that produce estrogen. So if you look at figure A, you can see that the ovaries are producing estrogen. So it's estrogen produced by the ovary in the cell. So what estrogen does, briefly, is suppress osteoclast activity, which is how bone is broken down. When the ovary starts to fail in menopause, the lack of estrogen increases osteoclast activity, and so it's unregulated, and it'll increase bone resorption, which is the bone breakdown. So this is the main concern in this population because of these hormonal irregularities, which can produce the loss of bone mineral density, leading to osteopenia, the risk for osteoporosis. So natural bone remodeling is a process of resorption followed by formation. So resorption is, like I said, the breakdown as by osteoclasts. Formation is by osteoblasts. It's the forming of new bone cells. So this is a kind of a brief overview of what that is. So you have the osteoclasts on the left, followed by osteoblast activation on the right, laying down new bone tissue. When there's equal ratios between the two, it leads to natural regulation of bone turnover and therefore bone mineral density. So this is just a little overview of the kinds of hormones that go into this process, which I won't discuss it because it's a lot and very in depth, but a lot of these hormones that regulate bone remodeling are in fluctuation during menopause and postmenopausal periods. So this leads to the risk for osteopenia and osteoporosis, which I said is caused by decreased bone mineral density, which is the unequal ratio of resorption to bone formation. So there's either a high increase in bone resorption and not enough bone formation, or just regular bone resorption and extremely decreased levels of bone formation. Ultimately, this breaks down the bone microarchitecture, leading to porosity and fragility, which in turn increases the fracture risk in this population. So on the left here, it's a little blurry, but on the left, you can see that a normal bone, the microarchitecture has less spaces. It looks stronger. On the right, in an osteoporotic bone, you can see there's more porous matter, and this causes a breakdown of the whole structure of the bone. So what exactly does bone density have to do with exercise? Well, it all comes down to mechanical loading. An overview. So what resistance training is a mechanical load of some sort, either weight, a band, your body weight, which stimulates increased and repetitive muscle contraction. What this muscle contraction does is it increases the accumulation of metabolites in the blood, in the muscles, which stimulates lactic acid and hydrogen ion release. So these are the primary metabolic accumulations that cause the release of growth hormone and IGF-1. This, along with the compression and tension on bone from the muscles and from the outside forces, causes an anabolic and hormonal response to signal mechanical reception in the osteocytes. This mechanical reception activates osteoblasts, which are bone-forming cells. So overall, when there's a stimulus, a force placed on the body, it will in turn signal hormones to signal activation from the bones. So this leads me to exercise prescription in postmenopausal women and what that looks like now. So primarily, like I said before, a lot of the research pertains to traditional resistance exercise in postmenopausal women. Again, resistance training will produce a mechanical stress, which it has been shown to produce extreme muscle adaptations, really important for quality of life. It has also many physiological benefits, cardiovascular, neuromuscular. They all come together to provide more adaptations to help health and quality of life. Under the realm of resistance training, there's primarily two that I'll talk about as high intensity and low intensity resistance training. High intensity resistance training is typically performance at about 60 to 80% of a 1RM. It's relatively high weight with a lower number of reps typically, shorter bouts of time because it challenges type 2 muscle fibers, which fatigue rather quickly compared to type 1 muscle fibers. It oftentimes requires a longer recovery period because of the increase in muscle damage caused by the high intensity, the high loads. This is specifically relating to increases in muscle hypertrophy, muscle strength, and rate of force development, as well as huge impacts on bone mineral density. Low intensity resistance training is usually about 40 to 60% of a 1RM, with a higher number of reps, can be done in longer periods of time because the type 1 fibers don't fatigue as quickly as type 2s. So in relatively healthy populations, it's used to increase muscle endurance. But with this, there's less research on the effects of low intensity on bone mineral density than there is with high intensity resistance training. This leads me to come to talk about Wolff's Law, which relates to mechanical loading and the effects of exercise. So briefly, what Wolff's Law says is that the higher the mechanical load, the higher the activation from bone remodeling. So when there's a force from the muscles on the body, it will, like I said, increase the activation from bone remodeling because the bones have to keep up with the forces being placed on it. So this is an important idea to remember as I go on. So as with anything with exercise prescription, there's always some risks and other considerations to take into account. Specifically with high intensity and even sometimes low intensity resistance training, with osteopenic or osteoporotic individuals, there's an increase in the bone fracture risk, especially if you're loading the body, especially if they're an untrained individual. Hopefully they wouldn't be automatically prescribed high intensity, but if they were to be and they're untrained, they're not used to that weight, they're not used to loading it, moving it, could lead not only to other musculoskeletal injuries, but also the risk for bone fracture, which we would like to avoid in this population. So other considerations. In the research, there was this argument or idea that, well, if high-intensity resistance training provides a higher risk, well, we can just prescribe low-intensity resistance training, which we know that there's many positive adaptations that come with low-intensity resistance training, but it may not be enough to produce increases in bone mineral density, which I think should be of main concern in postmenopausal women with osteopenia at risk of osteoporosis. So this leads me to BFR, blood flow restriction training. What it is a form, it's a more novel form of resistance training that requires effort at about 20 to 40% of a 1RM. Now, if you remember, low intensity resistance training, obviously without BFR, is between 40 to 60% of a 1RM. high intensity is 60 to 80%. So there's a fraction of the load needed to provide benefits in BFR. So it's a very attractive method for people at risk for bone fracture. So what BFR is a manipulation of vasculature during exercise by way of partial occlusion of the upper and lower limbs. You can do either upper at one time, lower at one time, or all four. It's done with an occlusion band, so proximal to the joint, and it partially occludes arterial flow and completely occludes venous outflow from the muscles working. So what this does is cause increased metabolic accumulation in the muscles during exercise, and induces protein synthesis, just like high-intensity resistance training would, with the response from growth hormone, IGF-1. It's all seen in the literature. So from Takarada et al., this research showed that the effectiveness of BFR is also dependent on the recruitment of type 2 muscle fibers at a faster rate than in high-intensity resistance training without BFR. So what this means, briefly, I'll explain the process of muscle activation. So during exercise, when the body is forced into muscle contraction, your body will recruit type 1 muscle fibers first before it recruits type 2 fibers. This is because type 1 fibers are oxidative and they are less metabolically demanding than type 2 fibers. So your body wants to conserve energy. But in BFR, the partial occlusion is forcing a hypoxic environment in the muscles, which means lack of oxygen. This lack of oxygen means that type 1 fibers will move through their energy system faster, and then will force the body to move into recruitment of type 2 fibers. So overall, this is done in a shorter amount of time than high-intensity resistance training, but it also has been shown to elicit less effect from DOMS, delayed onset muscle soreness. So that's another important factor in using this exercise prescription, because it produces less muscle damage, less recovery time, but with the same adaptations. So this is kind of just a pictorial idea of what goes on. So here you can see these are kind of what the cuffs look like. These are pneumatic and can be pumped up to a certain level of arterial occlusion and can be monitored. And so this forces vasoconstriction of the blood vessels. So like I said, it reduces the flow of blood, flow of oxygen, flow of nutrients, and keeps all of those metabolites in the muscles during exercise. It prevents them from being released. So when there's reperfusion, after removal of the cuff, there's vasodilation, increased vasodilation, and increase the reactive hyperemia that accompanies the release of these. So there's a huge influx of nutrients, oxygen, and it rushes the metabolites out of the blood. So these are kind of, I wanted to give some of the guidelines for this. So frequency, load, the time of restriction, the number of sets, and rest periods. A lot of it is similar to resistance training, except it shouldn't be done more than 20 to 30 minutes at a time. They recommend that reperfusion should be done between exercise 2 to 3 times per week, or 1 to 2 times per day, no more than that. And again, the load is 20 to 40% of a 1 RM. So current applications, I thought it was important to talk about this. So it's primarily used in healthy athletic populations, typically seen to compound the effects of like a normal weight training, resistance training program. It's also used in therapeutic settings, gaining popularity there with people who are injured or people who have been through surgery to prevent muscle atrophy. And it's gaining momentum in special populations. Something that I thought was interesting was that it's also been used in people with hypertension. So that was interesting. But just to show you that I'm not just making this stuff up, Ellefson and colleagues compared a 30% 1RM BFR protocol along with a high-intensity resistance training protocol in young women with no other conditions. They saw increases in growth hormone, hypertrophy in the quadriceps, an increase in the 1RM in a leg press for both groups. They were very similar and significant changes. While this information cannot be applied to postmenopausal women, it's very important to understand the effects of this type of exercise intervention. But Linero and Choi recently, they conducted a study that compared low-intensity BFR, low-intensity resistance training, and high-intensity resistance training in osteoporotic women. They saw the highest increases in blood lactate in the BFR group, which shows that there is an increase in the metabolic accumulation. They saw similar increases in 1RMs and the blood flow restriction and high-intensity resistance training groups. So they saw similar increases in muscle strength, which is important. But they also saw similar increases in bone turnover markers between BFR and high-intensity resistance training groups. And this was specifically important to my research because if they could see similar bone turnover markers, similar fluctuations in those, it implies that BFR may induce the same effects on bone remodeling that high-intensity resistance training does. So this shows that it's possible that high mechanical loading is not necessary to increase bone density. So of course, there's contraindications to this exercise, like I said, with anything. But specifically with BFR training, it's important that people with the history or the presence of a deep vein thrombosis don't participate in this exercise without prescriber acceptance. Diabetes is a contraindication, uncontrolled hypertension, or any other uncontrolled cardiovascular disease, and any sort of peripheral vascular compromise. But along with this, there's also safety measures that can kind of work to combat and keep these people safe if they are possibly experiencing something of a lesser extent than that. So, as I mentioned earlier, the use of a pneumatic device is really important. Non-pneumatic devices exist and they are still used, but a pneumatic device can limit the risk for injury of the skin or the nervous system. And it's also important that it's not done at more than 50% of arterial occlusion in the upper limbs and no greater than 80% occlusion in the lower limbs. Wider cuffs also have been shown to lower the risk of injury, be more effective in occluding the limb, and again, no more than 20 to 30 minutes of BFR. So this leads me to my research methodology and what I kind of came up with my proposal. So my aim was to evaluate the effects of a 12-week low-intensity blood flow restriction and a low-intensity resistance training protocol on bone density and muscle strength in postmenopausal women with osteopenia. The variables that I would test for would be bone-specific ALP and osteocalcin, which are direct bone turnover markers that signify bone health, bone remodeling phases, growth hormone, which would be a show of the metabolic accumulation, a leg press and a leg extension 1RM, which are the two exercises that will be done for muscle strength, and of course a bone density scan via a DEXA scan. The sample that the population that I would take the sample from would be untrained postmenopausal women diagnosed with osteopenia, which is defined as a T-score being between -1.0 and -2.5. The exclusion criteria is basically the same thing as the contraindications to BFR, but I included no T-score lower than -2.5 nobody with that T-score would be included. All of this would be addressed in the informed consent process, health history questionnaire, doctor approval, anything like that will be addressed in the informed consent so that the participants know of all the safety measures, the risks associated potentially with this training, and so forth. The design, I tried to make everything as randomized and controlled as possible, and as well as having the participants be allocated to 3 groups randomly. Some of the materials that I would use are a Katsu Master Pneumatic Cuff. It's one of the best out there. It's rather expensive, but it's the best at controlling the arterial occlusion with lower risk. A Doppler ultrasound technology would be used to assess the limb occlusion pressure to understand the level of occlusion that would be necessary at 50% for the lower limbs. Any equipment required for weight training, and any equipment required for blood draws and analysis, which would be done elsewhere in a lab. So as for the procedure, like I said, there's 3 groups: the control group, a low-intensity resistance training group, and low-intensity resistance training with BFR. The control group would not be experiencing any sort of exercise intervention. It would stand to keep the experiment controlled. The protocols for each of these experimental groups would be basically the same, except obviously the BFR would experience BFR. So it would be a 30% 1RM effort in a bilateral leg press and leg extension, meaning that blood flow restriction would be on both legs, not upper limbs, but just the lower limbs. And it would be 30 reps, 30 sets with 30 seconds rest in between and 5 minutes between each exercise. Hopefully this would be done 3 days a week with 48 hours separating each day. As for data collection, I would do baseline testing to get baseline values of everything, a 6-week and a 12-week test to evaluate the adaptations throughout the program. So again, the variables would be tested in each of the groups at each of these time points. And of course, appropriate statistical analysis will be done upon data collection. So overall, I think this would provide really important implications for BFR in postmenopausal women. I hope to see muscular adaptations, increases in hemodynamic function, improved hormonal regulation, which would be great, and the preservation and potential increase in bone mineral density. As for delimitations, I didn't get too much into this because I haven't conducted it yet, and I might not, but still, the only things that I could think about were diet, sleep, and other lifestyle habits that might impact kind of the results, but this would be addressed in the informed consent and be controlled as fully as possible. As for the future scope, I think that there could be a lot of different things done with this area because it's so underdeveloped. There's so much research to be done, but I think some of the main points that I wanted to take out of this were possibly using BFR in conjunction with hormone therapy, which I didn't discuss because it's out of my scope. But hormone therapy is available to this population, so it'd be interesting to see if they compound each other, what the potential effects of that could be. Potentially the effects of BFR training on osteoporotic individuals, other special populations. Now, a lot of the research does research osteoporotic individuals with BFR, but there's always a need for it. And then also the long-term application of BFR. A lot of the studies that I looked at, they were 8 weeks, 12 weeks. The longest one I saw was 6 months. So it'd be interesting to see if there is any long-term adaptations from this, or what the effect of detraining is, and what the maintenance of these adaptations would look like. That concludes my presentation. Thank you again all for listening. Any questions? Dr. Lachowski. Thank you.
Clarify a couple things because I think of what we said. So originally you had said, you keep saying partial occlusion, which really means restriction, right?
Mhm.
And then I think you had said complete venous obstruction. So that would actually mean complete occlusion. So you mean restricting venous outflow, correct?
Yes. Yes. Sorry.
Because what would happen if we completely occluded, like if we were taking someone's blood pressure or like taking someone's blood and we were actually tourniqueting off their arm and actually cutting off their brachial artery supply? What could happen?
It would not be good. There would probably be a lot of damage to the tissues in that arm, but there would also be issues throughout the body. I would assume with the heart not being able to pump that blood, potentially. I'm not sure.
Yeah, absolutely. There'd be a number of things, right? You have peripheral neuropathies potentially. Smaller vessels could get damaged. And have you ever heard of something called Virchow's triad for deep vein thrombosis?
I have, but I couldn't tell you exactly what it is.
Right, so there's a triangle of three components that is a recipe for a DVT. And two of them are stasis of blood flow, which would mean occlusion.
Yeah.
Right, and then, do you know the other two? One is endothelial injury. So, for example, if we were in surgery and someone's cutting through tissue, that increases your risk due to the healing process and all that. The last one is something called hypercoagulability, which is all of our clotting bleedings, right? But we could actually hit two of those if we occlude for too long. So that's
Right.
why it would be good to not occlude and or restrict.
Okay.
Secondly, I know you talked about a little bit of a wider cuff. We could talk all day about devices. This is a fun topic to talk about.
Yes.
But you said a wider cuff would potentially be beneficial, but you actually chose a thinner elastic pneumatic device. I'm going to go ahead and say I agree with your device on your reason.
Okay.
But why would a wider rigid cuff not be as beneficial as, say, a narrow pneumatic elastic cuff?
I believe a wider cuff requires more pressure in order to occlude the blood. So it could potentially cause pain, discomfort in the patient. Correct me if I'm wrong, but the smaller cuff would require less pressure to pump up the cuff and then therefore occlude the blood.
And think about biomechanics. If it's really wide, is that going to impede exercise technique at all?
Absolutely.
Right?
Yep. Absolutely.
And the big difference is something that's rigid versus elastic. Something
Yes.
that's rigid, what's the difference between that and something that's elastic?
So when we did our little lab, you could tell that when you have the cuff that's pneumatic, it kind of moves with your body, and it moves when you're exercising. Your muscles are obviously stressed if you're exercising, so it will move as the muscles move, if that makes sense. So if it was non-pneumatic and it wasn't able to fluctuate, pressure may be increased when you, so for example, if you're doing a bicep curl, the pressure may increase in your arm just from the muscle activation. But if there's a non-pneumatic cuff, it might be an increase in arterial occlusion, which we try to stay away from as we just established. So, thank you. Dr. Fefferly, I think you had a question. You've been very detailed with your questions to my classmates, so. No.
Go back to that slide that you said you were going to only talk about briefly with all the hormones on it.
I know it's close. Oh my goodness, I'm sorry. Okay. Okay.
Okay. The basis of your study. The question that you really wanted to know is, can I remove the basically disregard Wolff's Law and still get bone formation.
Yes.
Okay. And that is predicated upon the accumulation of these metabolites that you have talked about.
Yes.
What are these metabolites?
Specifically lactic acid and hydrogen ions.
Okay, lactate and hydrogen ions. Where are those coming from?
They are coming from the processes of, it's an energy breakdown system, right?
You are correct.
I can't remember what that is, which one that is.
3 bioenergetic pathways. I'll give you the 3, and then you tell me where I'm getting lactate and hydrogen.
Okay.
Okay. ATP-PC system,
Mm-hmm.
fast glycolysis, oxidative breakdown in the mitochondria. Which of those 3 am I going to end up? Could I potentially end up with lactate and a hydrogen? I'm graduating dependent.
Ooh, yikes. What was the second one again?
Fast glycolysis.
It was that one?
Is that a question or an answer?
It was that one, for sure. So that's where lactic acid comes from and hydrogen ions.
Technically it is an acid, but we could get into an argument.
Oh, lactate, sorry.
Technically it is an acid because it could donate a hydrogen ion.
Okay.
What is the relationship between this lactate and its friend hydrogen and ultimately these hormones that could potentially stimulate bone growth?
So when there's an accumulation, so of course I know what you're referring to is the idea that lactate buildup causes pain in the muscles, that burning sensation, which is not
Kind of.
true. Okay, so but the hydrogen buildup is what signals the growth hormone release and the IGF-1 release to repair and regenerate muscle tissue.
Okay, and what effect does growth hormone and its friend insulin-like growth factor have on either osteoblast or osteoclast activity? You can tell me otherwise.
So going back to the effects of exercise on the bone density slide that I had up, when growth hormone and IGF-1 are released, they are active long after exercise ceases. Correct me if I'm wrong, but that signals the osteocytes to activate the osteoblasts. I couldn't tell you much more, I guess.
Well, what do osteoblasts
Physiological.
do?
Osteoblasts,
Yeah.
they form bone.
So if I'm activating these osteoblasts because there's more growth hormone and insulin-like growth factor, what should potentially happen to bone mineral density?
It should increase.
And I did that all without having to load a bone.
Correct.
We'll swallow that down.
Correct.
Very good.
Okay. Thank you.
I don't know why you're all scared.
I'm not scared. I was expecting something that I couldn't answer. But
You all have.
thank you.
We good? You guys hear me? Hear me all right? All right, so Tariq and I did something a little different from the research review, went more along the basis of what Keith did with a community-based intervention, and with the times in today's world, we wanted to see how COVID-19 has affected adolescents' exercise habits and ability to set and achieve exercise-related goals. So a brief overview. Our research question is just that: how has COVID affected this population of adolescents for their habits and ability to progress and achieve within their exercise realm? So like I said, a community-based intervention, population high school students ages 14 to 18. Our subjects were 30 students participating in physical education classes at local South Hadley High School, about 20 minutes up the road. And what our initial idea was, or what ended up happening was, we sent out a survey to collect some data, and then we analyzed this data, put it all together, which we'll go through, but then we developed a educational resource pamphlet for these students to have as restrictions are lifting, the world's opening back up, and these kids can start to exercise and get back onto an exercise regimen. So this was revived from our original project plan. Tariq and I learned firsthand how difficult it can be to work with human subjects. And unfortunately, unlike Keith's kids enjoying to come see him every day, after filling out our survey, none of these students really wanted to hear much more from Tariq and myself. So we had to call a bit of an audible, and we came up with this general return to exercise from coming out of this pandemic, whether they had COVID or have just been sedentary for the last 12, 13 months. Just something for them to have. And a hypothesis to this question, we believe that by looking at this data that we were going to see pretty drastic decreases in exercise habits and their ability to set and reach goals.
So just a background of the coronavirus. If you've been living under a rock the past year and a half, you probably don't know what it is. So a little history about it. The coronavirus was first identified in the mid-1960s, and there are currently 7 known types of coronavirus, and they're named after their crown-like shapes, as you can see right there. The 4 common coronaviruses are 229E, NL63, OC43, HKU1. And 3 unique coronavirus cases are the MERS-CoV, the SARS-CoV, and the SARS-CoV-2, which is currently the one that we're experiencing right now.
So what is COVID-19 itself? This little name breakdown, it may seem simple, but I didn't really fully put it together till I saw that CO stood for coronavirus, VI was virus, and D was disease. So coronavirus disease, therefore COVID-19. And how does it affect the human body? Obviously, affects everyone differently. We've known that for a while now. People we know have reacted differently to having this disease. But as T was saying, with those crown-like proteins, what they do is they latch on to healthy cells within the lung and enter the cell through the ACE2 receptors. And what this can lead to, it can cause the lungs to become inflamed, where you'll get a lot of that dyspnea and labored breathing that we've heard a lot about. And it can also infect the alveoli, where, as we all know as exercise science students, that exchange between oxygen and carbon dioxide takes place. Technically, that's more going towards pneumonia and pneumonia-type symptoms.
So for our review of literature, I chose an article. The physical exercise is therapy to fight against the mental and physical consequences of COVID-19 quarantine. The special focus in the article was on the elderly population. So here's a quote from the article. From the point of view from a physiological functional reserve of organ systems, for example, to increase the CRF is cardiorespiratory fitness, is not only directly related with improvements in the circulatory and respiratory system capacities, but also increases in its functional reserve. For all this physical activity, exercise becomes especially essential for older people during the quarantine because it maintains physiological function and reserve of most of the organ systems, which could contribute to the fight against the mental and physical consequences and severity of COVID-19. So essentially, what this little blurb from the research article is saying, the benefits of exercise, such as improved cardiovascular, aerobic, anabolic benefits from it, can help combat against the deteriorations from contracting COVID-19. So review of lit continued. Exercise modality. A A multi-component exercise program is considered the most adequate for older people from both settings of free living and community dwelling. The multi-component exercise program includes aerobic, resistance, balance, coordination, and mobility training exercises. Two most important in that is balance and coordination for the elderly population. As you get older, you become more of a fall risk, and you want to keep on top of all those aspects to limit yourself to being a fall risk and getting hurt more frequently. Exercise frequency, the elderly population recommends 5 days per week, which in this particular quarantine citation could be increased to 5 to 7 times per week with adaptation in volume and intensity. Exercise volume under quarantine, 200 to 400 minutes per week distributed among 5 to 7 days to compensate for the decrease in normal physical daily activity. With a minimum of 2 to 3 days of resistance exercise should be performed. Mobility and balance training exercise should be performed daily. As I stressed before, the importance of it, exercise intensity. It is well known that exercise at moderate intensity improves the immune system, but vigorous intensity may inhibit it, especially in sedentary people. During quarantine times, moderate intensity, 40 to 60%, heart rate reserve, or 65 to 75% of maximal heart rate should be the ideal choice for the elderly population. These are a couple things you could do at home if you were an elderly person, or if you guys are just in quarantine by yourselves too. So for resistance training, we got bodyweight squats while holding a chair, sitting up and getting up from a chair, going up and down the stairs, transporting items with light and moderate weights. For aerobic exercises, we have walking inside. If you have a stationary bike at home, it's great to get on that. Walking up and down the stairs as well. And for balancing exercises, walking in a line on the floor, heel walks and toe walks, and stepping over pillows or creating obstacles for yourself to move over.
All right, so I'm going to walk us through the survey here, and then T will finish it off with the exercise packet we put together for these students. So you may be a little confused as to why Tariq was just talking about the elderly population when our study is about adolescents, and the fact of the matter is, and what goes into our needs analysis here, is that adolescents, in terms of COVID in the last year that's gone on, is extremely underdeveloped, and there's not a whole lot of research out there on how sedentary behavior and not having access to workout facilities or team sports or anything like that is affecting these students. So that's why we chose to work with this type of age demographic, as there was, as you saw, a lot of information out there on the elderly, a fair amount on collegiate athletes even, but not a whole lot on high schoolers. So what we wanted to assess here, we wanted to look at exercise-related goals. We wanted to look at the time they spent exercising, how they were exercising, what type of accessibility they had to exercise or exercise equipment, and self-efficacy, how they felt and how they feel when exercising about exercising. And the way we broke it up to collect all this information was we did pre-pandemic, which was before March 15th of last year, which, if you all remember, is when this lovely state of Massachusetts went into lockdown. And then the restriction period from March 15th to right now, and then all the post-pandemic questions are really about their goals and their aspirations and what these kids want moving forward out of the pandemic. So some results. Out of the 30 responses we got, we had 80% female, and the majority of those were all underclassmen, freshmen and sophomores, as you see there, 14 to 15, 16 to 17 years old. And the majority of them were white and Caucasian, so we'll talk about this a little later in our limitations, but obviously we would have liked to have a bit more of a diverse demographic to work with and pool all this information together. So going through these questions, be looking at each time period as opposed to going through each one individually. So did you have any exercise or physical activity goals set for yourself? Before the pandemic, about 56% of them said they did, and not 40%. I mean, we would like, as T and I looked at all this, and we'll go through it in the discussion, but ideally we would like to see these numbers get higher, especially in high schoolers. Kind of what Keith was saying, kids and adolescents are setting habits, they're forming habits. That's very much true in high school as well. And then you'll see during the restriction period, and this will be a common theme throughout our results, is that goal setting declined, and a lot of them weren't setting, but then a little positive note, uptick, 60% of them want to or have goals moving forward for after the pandemic, and we have some examples of those. Up here on the right, priority to keep my physique, so I'm happy and healthy, lose weight for bathing suit season, improve my mile time, get ready for spring sports, classic reasons for exercising and classic reasons for wanting to have exercise goals. How many hours per week did you participate in physical activity? So before the pandemic, about 40% of our students were participating in 1 to 3 hours a week, which, as we all know, the NACM or SM guidelines, that's not quite where we want to be, especially for young, active adolescent children, or teenagers, young adults. What was kind of frightening to look at and proved what T and I were kind of thinking is the restriction period, it went down to the majority of the students were exercising for under an hour at a time. So or less than an hour per week, excuse me. So you think 7 days, how many hours are there in a week? These high school students, the majority of which were athletes, were only exercising for less than an hour. And then moving forward, post-pandemic, those are the type of promising numbers we were looking for and wanted to see out of these students, that about a little above 50% of them want to be in that 3 to 5 hour plus range. So what was the average amount of time spent engaging in physical activity in a single session? Before the pandemic, about 35% of our students were in between a half hour and an hour, and as we all know, we like it to be around 60 minutes a day. There's a whole bunch of initiatives and motives out there. You see the NFL Play 60, wanting to get kids and adolescents outside, engaging in physical activity for at least an hour. And then similar to the last slide, you see this huge drop-off right here where the majority then started exercising for less than a half hour at a time. So that means if a lot of these kids are exercising for under an hour a week and under a half hour at a time, they're exercising once, maybe twice a week. Then, once again, after the pandemic, bright kids, motivated kids, it seems about a little over 60% of them want to be in that hour to 2 hour range per exercise bout. And then here we looked a little bit at the type of physical activity these kids were participating in. And as I mentioned earlier, about 50% of them are student athletes at South Hadley High School. And a good amount of them participated in aerobic and anaerobic work. But then you see here during the restriction period, as organized sports declined significantly, there was a significant uptick in aerobic and anaerobic exercise. And what we enjoyed seeing and looking at these results is after the pandemic, there's a higher uptick of these kids want to continue doing this type of exercise, more aerobic and anaerobic work, as well as their obviously organized sports as they continue to open up. So accessibility. We looked at organized sports, school gyms, home gyms, commercials, or none at all. And once again, organized sports was the primary source of physical activity and exercise for these students, but also see that school gym there. So we're up over 50% where these students, the subjects, had the primary source environment for them to exercise in was at school, which, as we know, was taken away from them for over a year at this point. They just got back to in-person learning about 2 weeks ago. The restriction period, there was a huge, kind of easy to guess, huge uptick in home gyms, home workouts. I'm sure a lot of us were in very similar situations where we had to get creative, start working out at home, finding different ways to be active and get our exercise in. And then there was a pretty great balance of what these students want to be involved in moving forward, having access to sports and all sorts of different workout environments. So the self-efficacy, questions, as we just kind of look at how these students felt about exercise and how they feel about themselves when they're exercising. So how much do they enjoy exercising? Not terrible. A 4 is pretty good, and we're up at about 40%. Only about 13% really loved it. And then that kind of mediocre range of 2 to 3 carry the majority of enjoyment. And the biggest benefit to exercise, gave them the option of athletic performance, fun, being in shape, or other. And being in shape took it home. And the reason being in shape is in quotation marks is, you know, especially for high school students, they shouldn't be focusing on really how their bodies look and the social image of all that. They should be happy and comfortable in their own skin. And if exercising a certain amount allows them to do that, then they should. But they should feel comfortable as they are and shouldn't have to think that there is a in shape that they need to get into. We got some interesting responses to how do these students generally feel about exercise. In the moment, they are awful. Exercise is not ever supposed to be easy, though, so I just have to keep pushing myself to the limits. When I finish exercising, I feel great, I feel motivated, high energy, and ready to take on the day. I think we would all love to have that type of outlook on exercise all the time, but I can tell you right now that there were multiple I don't like it, but I have to do it, and also quite a few I hate it. So quite a wide variety of how these kids feel about exercise. And then we wanted to look at how knowledgeable these kids felt in being able to practice safe and effective exercise techniques. And about 30% being at a 4, when T and I talked about it, we would say ideally we want these kids in high school to be in about a 3 and above. We don't want them exercising if they feel like they're a 2 or a 1 in terms of their ability to perform safe, effective exercises. They're not going to get the benefits and all the added benefits that come with exercising if they don't know how they're doing it and why they're doing it. So the discussion. The motivation to set exercise-related goals increased slightly from pre to post-pandemic, and our hypothesis was proven correct that hours spent both per week and per session during the pandemic decreased pretty significantly. And prior to the pandemic, about 50% of our students were participating in organized sports, and as we set up there, anaerobic and aerobic exercise decreased as organized sports declined. Also with that statistic about the home gyms, increasing by about 20% during the pandemic. And that's probably the biggest one that T and I were looking at, is about 77% of the students on that 1 to 5 scale picked a 3 or above for how much they enjoy exercising, which is obviously a positive sign in a pretty dark time.
So for our intervention, as Matt mentioned earlier, we had to throw an audible. We ended up going with a pamphlet packet about COVID-19 to distribute to the students at South Hadley High School. Originally, we wanted to have a second survey to collect more data to see any more changes and include informational Zoom sessions about anaerobic versus aerobic fitness and just giving them general knowledge on it to see if their confidence would improve, if they would enjoy it more and stuff like that. So the pamphlet we created, guidelines for returning to exercise. Whether you're a student athlete or an active individual who may or may not have suffered from COVID-19, you're most likely eager to get back into the groove of your exercise habits. Even if you have no symptoms or your illness was very mild, you may be wondering what activities as restrictions begin to lift. Here's some general information on how to safely do so. So being cautious. Something that Dr. Seifert, Dr. Lachowski has pounded into our heads since our freshman year was listen to your body. you have some lingering effects if you did come in contact with COVID-19. We obviously know more than we did over a year ago about COVID-19. Lingering effects such as damage to the heart, brains, lungs, and kidneys. This can lead to other lingering symptoms such as shortness of breath, loss of stamina, and exhaustion. All of these factors can lead to a reduction in both aerobic and anaerobic performance. The truth is, this pandemic has affected everyone differently. Some people may feel like they can jump back into things right away, while others still find a level of difficulty to do their either everyday tasks or exercise. Easing back into fitness. So listening to your body, like I said before, if you experience any type of symptoms such as chest pain or difficulty breathing, stop all physical activity. Immediately contact your healthcare physician. Exercise and physical activity is important for overall health, but for COVID-19, things can change overnight. Taking it easy. Don't try to overdo everything. Don't jump back into everything right away. All individuals, no matter what age or athletic ability, should follow a general gradual progression back into exercising. Jumping right back into where you left off can lead to injury and just prolong your return to exercise or even add on to what you're already experiencing in a negative way. Being patient. Even if you weren't the world's strongest man or woman prior to becoming infected with COVID-19, you'll soon discover that your body has changed in some sort of way, which warrants having extra caution. How to ease back into exercise/physical activity. Planning. One of the first steps before you dive back into a workout routine is to plan how and what you want to do and what your regimen to look like. Doing too much too quickly can lead to injuries, discouragement, and overall your mental state. Don't change everything at once. When you're in quarantine, everybody's eating habits changed, exercise habits changed. You don't want to change your diet and your exercise too rapidly all at once. Say before the pandemic, you were a 3-mile runner every day and you ate really clean. You want to get back into exercise post-pandemic, you can't just change your diet rapidly like that and jump on into running 3 miles. It has to be a slow progression. Taking a holistic approach, utilizing cool-down sets, stretching regularly, recovery, and healthy eating habits. Redefine what an amazing workout is. Try to find your why as to how you were a good athlete before, what motivated you, how you felt before and after a workout. Try to get back into that mental state and to establish a SMART goal. So right here, we're defining what a SMART goal is. Again, if you had Dr. Luchowski or Dr. Seifert, this is drilled into your brain. S in SMART goal is for specific. Your goal should be clear and specific, otherwise you won't be able to focus on your efforts and truly feel motivated to achieve it. What do I want to accomplish? Why is my goal important? Who is involved? Where is it located? And which resources can be utilized? Measurable for M. It's important to have measurable goals so you can track your progress and stay motivated. If you've ever tracked anything in your life, say weightlifting goals, progressions, anything like that, if you see the numbers go up, you're going to feel better about yourself. You're going to feel like you're doing the right thing and you're on the right path. A for achievable. Your coach also needs to find a realistic and attainable goal to be successful. In other words, if you should stretch your abilities, you should be able to stretch your abilities, but it still should be in the realm of possibility. Relevant. This step is to ensure that your goal actually matters to you and that you will align with your other relevant goals. We all need support and assistance in achieving our goals, but it's important to retain control over them. And then time-bound for T. Every goal needs a target date. When? What can I do 6 months from now? What can I do 6 days from now? What can I do a year from now? This allows you to track your progress and ties into all the other goals as well. So the timeline for returning back to sports and exercise, this is more along the lines of if you did contract COVID-19, the 10-day quarantine that everyone has to go through, no type of physical activity or exercise during that time period. It's important to rest, listen to your body, and stuff like that. NCAA and CDC COVID-19 recommendations. It's important not to exercise if you're feeling ill. This is especially important in exercising in a shared facility, say at a school gym, commercial gym, anything like that. You may feel the symptoms of your average cold, but any individual still may be infected. Maintain social distancing guidelines. Use sanitizers regularly, including before and after exercise. Do not touch your face before or after working out. And shared equipment should be wiped down. Simple stuff like that. And this is the NCAA's return to play protocol. If an college athlete has contracted COVID-19, your athletic trainer or your medical staff provider at the school will follow this. So it's a 7-stage level type of thing. Each day they will assess you to see what stage you're at, and progressively throughout the days they will try to get you to stage 7, and then once you're at stage 7 you can return to play your sport or activity. Limitations and future considerations. So virtual versus in-person, that was a big limitation. Not being to fully engage with people and like convey a little bit more emotion instead of sitting behind a camera really was kind of detrimental to our capstone project. Gender and race disparities, we had 80% female, 80% Caucasian, and most of them were ages from 13 to 14. Some other limitations that we had were honest answers with the survey. When conducting any survey, you don't know if your surveyees or respondents, respondees, that's what I'm looking for, are going to be honest or motivated to answer and read thoroughly through each question, give an honest answer. Lack of motivation to answer goes in that as well. So how we conducted the surveys was I emailed the guidance counselor at South Hadley High School, and she distributed these surveys to kids who were in physical education classes, and they were given a grade on it as well. So if they just did this quick survey to get a grade or they're actually interested, we will never know. General human error is another big one. Respondent bias, or if they were uncomfortable answering certain questions, they might have just put down anything to get it done with. And unconscious responses. If the questions might have been a little too hard or they had key terminology that they didn't understand and they answered unknowingly.
And then, yeah, this last one here, what T and I really wanted to do, if we had the opportunity to be in person or even to be over Zoom, was get some type of physical attribute comparison from before the pandemic to where they are now. These kids have been primarily sedentary for well over a year now. That's obviously going to come with pretty significant body composition changes, the amount you're exercising, the amount you're eating, how you're eating. So it would have been nice for us to be able to, kind of compare, like these kids are still growing too, compare the height, weight, VO2 max in an ideal world, and then just get that BMI and see where they are and how this pandemic has affected them on a personal, physical level. References and questions.
Dr. Wachowski. Some key things that I learned are kids are tired of interacting with other people through a computer. So one of the biggest problems with our survey, with our capstone project, like I mentioned before, was not being in an in-person setting and trying to convey what our pitch is and what we're trying to do for these people. And everyone's been affected in a different way from this pandemic, and yeah.
I think for me it came in what research we were actually able to find. When we were talking about the elderly, obviously the elderly were hit particularly hard by COVID, and a lot of us have lost elderly loved ones, and that's a very good reason for there to be a lot of research on that subject. But the fact that it is all primarily focused, when you look, it is elderly and NCAA athletes is the majority of the research that is out there. So that was kind of surprising to me that high school students and even maybe younger than that weren't getting as much detail and attention.
It's always good to have a backup plan, no matter what.
Always good to have. You can't always rely on human subjects. It's their decision. So, but it was a good experience. This is the first time we've ever, conducted something with other people that we were in charge of and we were coordinating. So, now we know going forward how difficult it may be, especially with that type of age demographic, to elicit the type of responses you want.
Dr. Pfefferly. Oh, Michaela.
Yeah, I think it's good, especially even if you're not an athlete, to have some sort of idea, grasp on physical activity, how to keep yourself healthy. To be honest, what Keith was doing with his capstone, that's the type of thing that I think a lot of us would like to see all over the place, is somebody who's committed to kids at a young age, wanting them to develop and learn to love exercise and how to safely exercise, so that when they do go through middle school, high school, and then to college, whether they're playing sports or not, they have the tools and they're equipped with what they need to live a healthy, active lifestyle.
Just to piggyback off that, the audible that we did throw, what we were going to do is have an informational session and teach them concepts like this if they didn't understand any keywords or anything from what we've learned through college.
Dr. Pfefferly.
What is the difference between self-efficacy and self-esteem? You said you measured self-efficacy, but what are those two terms? They're very similar.
So self-esteem is how you view yourself and all the other attributes that contribute to that and how you perceive other things. Self-efficacy is your confidence in your ability to do a task. So how confident am I in lifting this barbell or getting through this test or doing this presentation, something like that.
Could one of those affect the other?
Of course.
Absolutely.
What direction is that cause and effect in that area?
So if your self-confidence is low, you're not going to believe in yourself as much, have enough confidence in yourself, and then that will translate to everything that you do. If I had low self-confidence, my generalized, if I had low self-esteem, that's low self-esteem, my view on self-efficacy for doing tasks would also be low too, because of the psychological standpoint of you viewing things as being very negative or not being good enough to do something.
I think it works inversely too. If you have, if you're not confident in the ability to lift a certain amount of weight, then you're probably not going to feel great about yourself because you're looking at this weight that you can't lift, and that's not going to help your self-esteem. So I think the relationship could go both ways.
Is self-efficacy a generalized concept or is it task specific? Let me ask you this. Should I have high self-efficacy lifting the barbell and low self-efficacy giving this presentation?
Yes.
So is self-efficacy a generalized concept or topic specific?
Task-oriented.
Task, yeah.
All right, well done, seniors. Let's give everyone one more round of applause. Very, very well done. I'm sorry, I know we did go over a little bit of time here. Everyone, thank you for coming. I will need you all the guests to sign in really quick on one sheet that you are here. I do have one thing for everyone before you go, so hang tight for just a minute. And seniors, also hang tight so we can talk a little bit about next week if you just have a minute. And I want to get a group photo up there afterwards. Okay? All right, so thank you all for coming, and best of luck on the rest of your finals.